The first thing to be brought up when arguing with a person who wants increased state control of medical services is life expectancy. Now, here are the life expectancies for the people living within the borders of the area claimed by the following states. Japan, 83 years. Australia, 82 years. Switzerland, 82 years. Canada, 81 years. Spain, 81 years. Italy, 81 years. France, 81 years. Germany, 80 years. Britain, 79 years. And the United States, 78 years. And from this, one is to assume that it is the national healthcare system that causes these gaps. Right? That is, Japanese people live for 4 years longer than British people because Japan has a universal healthcare system while Britain does not. Oh, wait a minute, Britain does. But still, the only area that doesn't have a universal healthcare system does have the lowest life expectancy. However, and this is a quote from an article from Reason.com, which I will link to where the links are. Quote, Texas A&M health economist Robert Osfeldt, hope I'm pronouncing that correctly, Robert Osfeldt, and health economics consultant John Schneider point out that deaths from accidents and homicides in America are much higher than any other of the developed countries. Taking accidental deaths and homicides between 1980 and 1999 into account, they calculate that instead of being near the bottom of the list of developed countries, U.S. life expectancy would actually rank at the top. Close quote. Also, the article points out, with appropriate links, that Americans are more likely to have low birth weight than any of these other developed countries. And that for any baby born with a low birth weight, that baby is more likely to die in Canada than a hospital in America. So even though more babies die of low birth weight in America, if you are a low birth weight baby and you're born, you're more likely to live if you're born in America than if you are born in Canada. Also, people living in the area called America are also very fat. 31% of them are obese, however, obese is defined. And looking at these factors, it appears to me that the healthcare situation in the place called America is actually doing a pretty good job saving the lives of a people with very unhealthy proclivities. That said, the U.S. healthcare system is not even entirely private. First off, there is Medicare and Medicaid, and these programs subsidize the use of medical services. If part of a person's medical bill is automatically paid by another person, he will use more medical services, a lot more in fact. Let's say at the cost of $10 per unit of medical services, and let's pretend that like medical services is like a brick. You get a brick of medical services, okay? At a cost of $10 per unit of medical services, Bob will buy 10 units of medical services at the cost of $100. Now, if part of his medical bill was subsidized, let's say 50% for simplicity's sake, he would be spending himself $5 per unit of medical services. Now, he is actually paying taxes, but he has no choice over that. If he buys more units of medical coverage, he still gets the subsidy, and his taxes don't rise as a result of him personally buying more units. Right? Because, I mean, there's 300 million more people. He has virtually no effect on how much taxes he pays based on how much he buys. So if Bob is willing to spend $100 on 10 units under the subsidized program, how many units would he buy? Well, odds are more than 10. Let's say he goes halfway and buys 15 units of medical services at a cost to him of $75 and at a cost to the taxpayers of $75 as well, because there's a 50% subsidy. But he has bought more medical services than he would have if it was not subsidized. But, of course, because everyone does this, medical services are subsidized, so everyone buys more, all that happens is that the price of medical services increases. Because there aren't actually more medical services, at least not right away. Actually, there aren't more medical services because supply is restricted by the state, which I'll get into a later section, but because everyone is buying more medical services and it's subsidized for everyone, there's not more medical services to buy, and so all that ends up happening is that the prices go up. And Bob eventually finds himself buying 10 units of medical services for $200 now, or for $200, and then the other $200 are subsidized by the taxpayer. What ends up happening is that more money is spent on the same number of medical services because it's subsidized. medical care becomes more expensive because more people are willing to buy more units because of the subsidy. And this is why healthcare in the U.S. is so expensive, and why, oh so predictably, it is blamed on the free market. Because it's not directly run by the state, it's just massive amounts of state intervention that screws up the market, and so it's then blamed on what is supposed to be a free market. This is also why healthcare was cheaper in real terms in the 1960s and 70s than it is today. And as a result of this subsidy, people living inside the U.S. spend more on health services than people who live in areas claimed by states that have universal health care. And I don't know if universal health care would be better or worse than the current situation. However, Obama is intent on exacerbating the problem by increasing the subsidies. Increasing the subsidies will increase the amount people are willing to spend on medical services, and then they end up spending more. But of course, the medical service supply doesn't actually increase, and all that ends up happening is more total money is being spent, which will make universal health care look more appealing compared to this mess, which is what's happening now, right? Universal health care is becoming more and more appealing because of this massive subsidy inflating all the prices. Inflating all the prices and not raising the actual supply of medical services. In the United States, citizens actually get treated for conditions less than in Canada overall. However, white Americans get more treatment for conditions than white Canadians, and black Americans get more treatment for conditions for black Canadians, etc. Right? Put it this way. There are more, as a percentage, there are more blacks and Mexicans in America than in Canada. So I don't know about Mexican immigrants, but I know that a black American has more access to medical services than a black Canadian. A white American has more access to medical services than a white Canadian. However, because Canada as a percentage is more white than America, the whole population of Canadians overall have more access to medical services than Americans. They get treated for existing conditions more than Americans overall. Also, because Americans still pay a great deal of their own healthcare costs, Americans actually buy more preventative medicine than Canadians. Canadians overall get treated for existing conditions more than Americans overall. However, white Americans get treated for existing conditions more than white Canadians, and black Americans get treated for conditions more than black Canadians. Right? So if you are a black person, it's better to be in America than Canada. If you are a white person, it's better to be in America than in Canada. If you are born with a low birth rate, it's better to be in America than in Canada. And I would suspect that if you are obese, it's better to be in America than in Canada. However, the health statistics for the U.S. look worse because there are more people with low birth weights, more people who are obese, and more black people in America than in Canada. And there's still some economic inequality in the U.S. between blacks and whites for reasons. Okay. So in Canada, Canadians don't get as much preventative medicine than Americans, because in Canada people just say, "Oh, the state will take care of me," and so there's less incentive to get to prevent the onset of those conditions. Now, I'm not saying that there's no incentive, because nobody likes to get sick. Right? I mean, people will eat healthy because they want to be healthy, right? And it doesn't have, and maybe healthcare costs have something to do with it, but people like to be healthy for its own sake, right? I'm not trying to boil everything down to one factor. However, if the cost of being sick comes directly out of your own pocket, you will take more steps to not get, buy more preventative medicine, right? I mean, and it's easier to buy more preventative medicine than to change your dietary habits, right? So, anyway, maybe I shouldn't have gone into that. That's a little bit nuanced there, but like, if all of your medical services are coming out of your own pockets, it would make sense for you to get more preventative medicine. It would also make more sense for you to eat healthier than Canadians eat. However, eating healthier, I think that's a bridge too far for Americans. Like, Americans are willing to pay more for preventative medicines, but are not willing to change their dietary habits. That's a bit a bit maybe considered a bit of an extreme measure for a lot of Americans who love their greasy, fatty foods. So now, no individual or organization earns income off of medical service equipment in a state society. So in a universal healthcare system, you tend to have less and more overused equipment. From the Healthcare Economist article that I have linked into where the links are for this, they say, quote, "The reason is simple. In a system characterized by private property and some sort of private payment, capital facilities are assets. The owners can earn a rate of return on them. Thus, it makes no sense to permit such facilities to deteriorate. Capital in a system like Canada's, however, is a liability. No individual or organization earns income from these things, and payment for their purchase takes away from the individual employees, many of whom are unionized. Bureaucrats buy less equipment because they get paid a prescribed budget from a central planning committee, and that equipment that they have is overused to the extent that it is free." Right? Because buying new equipment, that's just money that comes out of their salary. Right? It's not capital to them, it's just an expense. And this is why you have long waiting periods in Canada, right? And it's the same reason you have long lines at the DMV and why there are long lines for everything in the USSR. And by waiting periods, I don't mean like, oh, you're in the waiting room for like 10 more minutes. No, that's not what I'm talking about. I'm talking about waiting months for an operation. Also, keep in mind that when someone dies as a result of not getting treatment for a fatal disease, that actually makes the universal healthcare system appear more cost effective, because instead of having that expensive heart surgery, right, the guy died after having to wait in line for 4 months for a heart surgery. Right? So dead people tend not to rack up a whole lot of medical expenses. And so what that does, people dying actually makes the universal healthcare statistics look a lot better. When you subsidize healthcare, does that increase the number of doctors? Not right away. And there are only so many people who are willing and able to become doctors, and that's how much medical service there actually is. Making it free, making medical service free, does not change that fact. But that said, the supply of doctors is significantly restricted. Second post on medical services. In 2007, we can deduce that the U.S. government spent about $3,596 per person on a medical service, while Britain spent $2,444, Canada spent $2,726, and Australia spent $2,176 per person. Despite this, in the U.S., $4,324 per capita was spent on medical services in the private sector, compared to only $548 in the United Kingdom, $1,169 in Canada, and $1,024 in Australia. And of course, I can explain this by saying that this is because the U.S. government subsidizes medical services, but supply does not increase in response to the subsidy, and so all that ends up happening is that more money is spent on the same supply. And so increasing the subsidy, increasing the amount of money spent on medical services is not going to change anything because supply is not being raised, right? If supply is not being raised in response to the subsidy. So here are the physicians per 1,000 people in each of these states. Despite the U.S. spending much more, they don't have any more physicians in the U.K. Australia has about 2.88 physicians per 100 people. The UK has 2.48, the US has 2.43, and Canada has about 2.18. Now, before one hoots and hollers and clamors for more state control, let's look into this. Why is so much spent on medical services in the US? Well, in Britain, the NHS acts as a price control mechanism on medical services, and this keeps prices low. But everyone in the UK wants to use the medical services that are now either artificially cheap or free. The result is long waiting lines and sometimes just outright denial for operations. In fact, by denying services, the NHS can lower the wait times for the remaining patients. And this is what occurs in Canada and Britain, and my guess is what happens in Australia and New Zealand. In 1972, Richard Nixon imposed price controls on gasoline, and the result was waiting lines and rationing. Right? And this is what happens with the NHS and their healthcare system. And you can call these death panels or not, but there's not an infinite supply of medical services, and they are rationed one way, and like there's a limited supply of medical services, and they are going to be rationed one way or another. In the United States, there are less price controls, and the result is that the prices of medical services are just bid up and up and up and up. On a free market, this would be no problem, right? Because there's a huge profit incentive for would-be doctors. So on a free market, we would see tons of Americans becoming doctors and wanting to get in on those big paychecks. And this increase in the supply of doctors would drive the price of medical services back down in the same way an increase in the supply of any product would. Unfortunately, thanks for the lobbying efforts of the American Medical Association, the supply of doctors is legally restricted. Now, I personally am a little bit ambivalent if the U.S. goes to an NHS-style medical system. That system has some pros and cons depending on how rich you are, and on the whole may actually be better than the current state of affairs in the U.S. The problem is that the current problems in the U.S. are being blamed on the free market, right? When the real culprit is the state and the AMA for limiting supply. In America, it's the devil take the hindmost, and the reason people pay so much is because they're paying to not die. In Britain, instead of devil take the hindmost, it's random death. It's bureaucratic death. So, and don't be fooled by coverage. There are about as many physicians per person in Britain as in the U.S. There's just as much coverage in Britain as in the U.S. The only way to solve this problem is through freedom. Remove the restrictions on supply, and the supply of doctors will rise and the price will fall without having to resort to death panels. Right? And I mean, that's what they are. They're panels that will decide who will get services and who will probably likely die. Because of state regulation, the supply of doctors is artificially limited, meaning that prices in the U.S. will either always be high, or the U.S. could become like the U.K. and just have really long wait times. So what do you want, high prices or really long wait times? And this does not mean waiting another hour for an appointment. It means like waiting for 2 months for an operation. Here is an article that I will link to wherever the links are. How Government Solved the Healthcare Crisis by Roderick T. Long. And this is Roderick Long's writing here. Today, we are constantly being told the United States faces a healthcare crisis. Medical costs are too high and health insurance is out of reach of the poor. The cause of this crisis is never made very clear, but the cure is obvious to nearly everybody. Government must step in to solve the problem. 80 years ago, Americans were told that their nation was facing a healthcare crisis. Then, however, the complaint was that medical costs were too low and that health insurance was too accessible. But in that era, too, government stepped in forward and solved the problem. And oh boy, did they solve it. In the late 19th and early 20th centuries, one of the primary sources of healthcare and health insurance for the working poor in Britain, Australia, and the United States was the fraternal society. Fraternal societies, called friendly societies in Britain and Australia, were voluntary mutual aid associations. Their descendants survive among us today in the form of the Shriners, Elks, Masons, and similar organizations, but these no longer play the central role in American life they formerly did. As recently as 1920, over 1/4 of all adult Americans were members of fraternal societies. The figure was still higher in Britain and Australia. Fraternal societies were particularly popular among blacks and immigrants. Indeed, Teddy Roosevelt's famous attack on hyphenated Americans was motivated in part by hostility to the immigrants' fraternal societies. He and other progressives sought to Americanize immigrants by making them dependent for support on the democratic state rather on their own independent ethnic communities. The principle behind the fraternal societies was simple. A group of working-class people would form an association, or join a local branch or lodge of an existing association, and pay monthly fees into the association's treasury. Individual members would then be able to draw on the pooled resources in time of need. The fraternal societies thus operated as a form of self-help insurance company. Turn-of-the-century America offered a dizzying array of fraternal societies to choose from. Some catered to a particular ethnic or religious group, others did not. Many offered entertainment and social life for their members and engaged in community service. Some fraternal societies were run entirely by and for women. The kinds of services from which members could choose from often varied as well, though the most commonly offered were life insurance, disability insurance, and lodge practice. Lodge practice refers to an arrangement reminiscent of today's HMOs, whereby a particular society or lodge would contract with a doctor to provide medical care to its members. The doctor received a regular salary on a retainer basis rather than charging per item. Members would pay a yearly fee and then call on the doctor's services as needed. If medical services were found unsatisfactory, the doctor would be penalized or the contract might not be renewed. Lodge members reportedly enjoyed the degree of customer control this system afforded them, and the tendency to overuse the physician services were kept in check by the fraternal society's own self-policing. Lodge members who wanted to avoid future increases in premiums were motivated to make sure that their fellow members were not abusing the system. Most remarkable was the low cost at which these medical services were provided. At the turn of the century, the average cost of lodge practice to an individual member was between $1 and $2 per year. A day's wage would pay for a year's worth of medical care. A day's wage would pay for a year's worth of medical care. By contrast, the average cost of medical service on the regular market was between $1 and $2 per visit. Yet licensed physicians, particularly those who did not come from big-name medical schools, competed vigorously for lodge contracts, perhaps because of the security they offered, and this competition continued to keep costs low. The response of the medical establishment, both in America and in Britain, was one of outrage. The institution of lodge practice was denounced in harsh language and apocalyptic tones. Such low fees many doctors charged were bankrupting the medical profession. Moreover, many saw it as a blow to the dignity of the profession that trained physicians should be eagerly bidding for the chance to serve as the hirelings of lower-class tradesmen. It was particularly detestable that such uneducated and socially inferior people should be permitted to set fees for their physician services, or to sit in judgment on professionals to determine whether their services had been satisfactory. The government, they demanded, must do something, and so it did. In Britain, the state put an end to the evil of lodge practice by bringing healthcare under political control. Physicians' fees would now be determined by panels of trained professionals, i.e., the physicians themselves, rather than by the ignorant patients. Self-financed medical care edged out lodge practice. Those who were being forced to pay taxes for, quote, free, close quote, health care, whether they wanted it or not, had little incentive to pay extra for health care through the fraternal societies, rather than using the government care they had already paid for. Right? Health care was made free to use. In America, it took longer for the nation's healthcare system to be socialized, so the medical establishment had to achieve its ends more indirectly, but the essential result has been the same. Medical societies like the AMA imposed sanctions on doctors who dared to sign lodge practice contracts. This might have been less effective if such medical societies had not had access to government power. But in fact, thanks to government grants of privilege, they controlled the medical licensure procedure, thus ensuring that those in their disfavor would be denied the right to practice medicine. Such licensing laws also offered the medical establishment a less overt way of combating lodge practice. It was during this period that the AMA made the requirements for medical licenses far more strict than they had previously been. Their reason, they claimed, was to raise the quality of medical care, but the result was that the number of physicians fell, competition dwindled, and medical fees rose. The vast pool of physicians bidding for those lodge practice contracts had been abolished. As with any market good, artificial restrictions on supply created higher prices and a particular hardship for the working class members of fraternal societies. The final death blow to lodge practice was struck by the fraternal societies themselves. The National Fraternal Congress, attempting, like the AMA, to reap the benefits of cartelization, lobbied for laws decreeing a legal minimum on the rates fraternal societies could charge. Unfortunately for the lobbyists, the lobbying effort was successful. The unintended consequence was that the minimum rate laws made the services of fraternal societies no longer competitive. Thus, the National Fraternal Congress's lobbying efforts, rather than creating a formidable mutual aid cartel, simply destroyed the fraternal society's market niche, and with it the opportunity for low-cost health care for the working poor. So, why do we have a crisis in healthcare costs today? Because government solved the last one. And just a quick response to someone who may say, well, sure, stricter licenses on doctors does decrease the supply of doctors, but that's good because now the doctors that we do have are better, and we won't have people buying poor doctors or buying services from shoddy doctors. Problem with that, what ends up happening in reality is that you have less doctors and they become overworked. So yeah, you have more overworked doctors, and what's more is, of course, we know there's ways to make sure your doctors are of high quality. There's ways to review doctors in the field, as we would do with cars. But apparently, doctors we don't want to have a reviewing system with doctors. Like, we're able to, we'll spend lots of time reviewing the quality of our cars, but not spend a whole lot of time reviewing the quality of our doctors that could save our lives. Here we have the physicians per 1,000 people by country, according to sources compiled by NationMaster, and the link to this will be where the links are. Cuba, 5.91 physicians per 1,000. Belarus, 4.55. Greece, 4.4. Russia, 4.25. Italy, 4.2. Turkmenistan, 4.18. Georgia, 4.09. Lithuania, 3.97. Belgium, 3.9. Israel, 3.82. Uruguay, 3.65. Iceland, 3.62. Armenia, 3.59. Bulgaria, 3.56. Azerbaijan, 3.55. Kazakhstan, 3.54. Czech Republic, 3.5. Austria, 3.4. Germany, 3.4. France, 3.37. Portugal, 3.3. Sweden, 3.3. North Korea, 3.29. Lebanon, 3.25. Hungary, 3.2. Spain, 3.2. Estonia, 3.16. Norway, 3.1. Holland, 3.1. Slovakia, 3.1. Latvia, 3.01. Argentina, 3.01. Ukraine, 2.95. Denmark, 2.9. Ireland, 2.79. Uzbekistan, 2.74. Luxembourg, 2.7. Moldova, 2.64. Mongolia, 2.63. Finland, 2.6. Kyrgyzstan, 2.5. Poland, 2.5. Croatia, 2.4. Cyprus, 2.34. United States, 2.3. Are we really going to say that Cuba, Belarus, Greece, Russia, Turkmenistan, Georgia, Lithuania, Armenia, Bulgaria, Azerbaijan, Kazakhstan, North Korea, Lebanon, Hungary, Spain, Estonia, Portugal, Latvia, Ukraine, Uzbekistan, Moldova, Mongolia, Kyrgyzstan, Poland, and Croatia have more people willing and able to go through medical school and become doctors than the U.S.? Now, perhaps the number of doctors in Cuba is artificially high because of state intervention, or maybe the stats are fudged. But even if we throw Cuba out, like Turkmenistan, that there is the problem in the U.S. And I would say is also a problem in all the European states on the list, and that is supply is restricted.